When walking with the patient, the therapist should never be on her sound side. Her whole weight is on a sound arm and leg, and her trunk leans over towards a quadruped when making a step with the affected leg. All various phases of walking can be prepared for in standing. This prevents hyperextension of the knee while doing the inhibition of flexor spasticity of the arm. The therapist is by her affected side. The patient is then asked to move her hip towards her and help to transfer her whole weight towards the affected side. She is asked to make very small steps forward and backward with the sound leg. The patient should not be allowed to lift her leg high up, as she can only do this by pulling up her pelvis. Instead, before making a step, she should be helped to release her knee and bend it slightly with her pelvis lowered, and then to bring her flexed knee forward. The therapist bends the patient's knee until there is no resistance to flexion. She is then asked to hold it flexed and to maintain it in various degrees of flexion when the leg is gradually extended by the therapist. The patient should now stand with her full weight on the sound leg, the affected one slightly behind it. She is asked to relax and bend her affected knee, adducting his thigh so that her knee comes near the sound one. The patient should also practice doing small alternating movements of flexion and extension of her knee. When she can do this without stiffening her knee, she should be asked to make a step forward. The therapist may guide her foot, controlling her dorsiflexed toes to prevent supination and pressure against the ground when she puts it down in front. Pulling up of the pelvis is prevented by the therapist. Putting her foot down in front, the patient should learn to control the weight of her leg as she lowers it towards the ground. When asking the patient to make a step, the therapist controls the foot in dorsiflexion and checks whether there is any pressure of the foot against her hand. The therapist holds the patient's hand with wrist and fingers extended and the thumb abducted. When resistance of wrist flexors has been reduced, abduction of thumb with extension of fingers only is needed. After successful inhibition of flexor spasticity, the position of the arm can be actively maintained with little support by the therapist. She now holds up arm unaided. In supine or sitting, the patient is now able to hold her arm up extended above her head. She bends her elbow to touch the top of her head, followed by moving her hand to the opposite shoulder, then back again to her head. Touch the opposite ear, and then move her hand to the shoulder and down the arm, as if washing herself. Flexion of the elbow with supination brings her hand to her mouth. Shoulder retraction must be prevented. She learns to control movements which she needs for the functional use of her hand later on. The patient clasps her hands and interlocks her fingers with the thumb of the affected hand over that of the sound one. Her wrist should be in semi-supination and extended. In sitting or standing, she moves her hands above his head. This is followed by putting her clasped hands behind her head and then raising them again. Next, she puts her clasped hands on her chest, and then she extends her arms forward so that her hands touch a wall.